Hello, everyone. Welcome to today's presentation on Medicare and hospice care. I'd like to particularly thank our co-hosts at the Coalition to Transform Advanced Care for helping make today's presentation happen. My name is Matt Shepard. I'll be handling the technical side of things today. And our speakers today include Center for Medicare Advocacy Associate Directors David Lipschitz and Kathy Holt, Center for Medicare Advocacy Senior Attorney Wei Wei Kwok, Katie Weary from the National Association for Home Care and Hospice, Brian Lindbergh from co-host Coalition to Transform Advanced Care, and Ethan McChesney of the National Partnership for Healthcare and Hospice Innovation. So we have an incredible wealth of knowledge here today for you. You will hear a little bit more about our co-hosts and the other organizations a little later, but a little bit about the Center for Medicare Advocacy. As many of you know, and as shown on this slide, the Center is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities. The Center focuses on the needs of people with longer-term and chronic conditions. And the work includes legal assistance, advocacy, education, analysis, policy initiatives, and litigation of importance to Medicare beneficiaries nationwide, all based on the experiences of the real people who contact the center every day. Now, before I pass things off to David to get us started, let me talk a little bit about this GoToWebinar system. Today's session is going to be familiar to a lot of folks on here, I know. It's going to look like a little streaming news show, complete with talking heads, so do bear with us as we get those cameras on and off for our speakers. Only our speakers have video capability, and in addition, I will be keeping the crowd muted during the presentations because we're going to have quite the large audience today. On the topic of audio, I hope everyone is hearing me right now. So that means you use the information in the email you received after registering to successfully log in, and you've either dialed in by phone or you've got good quality working speakers on your computer, either of which will be just fine. As you're all likely aware of these days, audio and video quality are going to be at the whim of your hardware and your internet connection. Video will be what it will be, but if audio is an issue, on the computer, you can always dial in by phone using the number that was provided on your confirmation email. That number is also available under the audio tab on the control panel that you should see at the right of your screen. Although that said, I have heard that we are having nationwide cell carrier issues today. So even that might be iffy technology. Speaking of the control panel that I just mentioned, I am sure that, again, many of you are familiar with this, but there are a couple key features for our purposes today. Please look at the buttons on the tab at the left side of the panel. There's a little orange arrow that'll let you hide that panel so it's not in your way. There's a little square that lets you watch the presentation in full screen mode. And then there's a little picture of a hand. That's going to be used to indicate that you have a question or comment. While our presenters provide their info, as noted, attendees will be muted, but when we open it up for questions, comments, etc., you can use that little hand icon if you'd like to speak, at which point I can unmute you, at which point we usually have a little dance of me unmuting you, you unmuting yourself, which actually mutes you, etc., etc. So please just be sure you are not self-muted. You can look at your little microphone, and then that should work out fine for us. If audio is an issue still, you can always type questions into the questions section of that control panel, and I will do my best to pass those on to our presenters. As mentioned, however, we have kind of a massive audience today, so we will certainly, I promise you, not get to every question, and we do appreciate your patience in that regard. Please note, we also did solicit some feedback on our registration form, and David and the others will try to address some of those themes that were brought up on those forms. Finally, from me, you should have received a copy of today's slide deck in an email prior to the presentation. If for some reason those did not make it to you, you can go to the handouts section of the control panel and download a PDF right now live. I want to thank everyone again for attending, and now I'll hand things over to Associate Director David Lipschitz to get us started for real. David.
Thank you, Matt, and thanks to all of you for joining us today. It's not a particularly profound insight to say that our society or culture is not the most comfortable when or with confronting our own mortality or that of those around us. It is for this reason, in part, that the hospice benefit is one that is often misunderstood with respect to its purpose, intent, what is available through the benefit, and what it means to elect hospice coverage. When hospice is properly understood, elected, and administered, it can be a pathway to comfort and dignity for those on the end of life journey and their caregivers and caretakers. The recent and ongoing experience of former President Jimmy Carter and his hospice journey has raised visibility and hopefully sparked discussions about the end of life. The hospice benefit can also, unfortunately, be exploited for improper gain. There has been growing concern in recent years about unscrupulous actors engaging in fraud, including targeting of people who are inappropriate for hospice care, as chronicled, for example, in a November 2022 New Yorker article. There are many sources of information about the hospice benefit, including from all the organizations in this webinar. But here at the Center for Medicare Advocacy, it's been a while since we've held a webinar discussing these issues. So we wanted to offer a broad-based information set in an effort to appeal to a wide potential audience with varying exposure to or experience with hospice. We decided to provide both practical and policy discussions today with the help of a panel that I will introduce in a moment. Note that unlike our usual webinar running times of 1 hour, we are running this one for an hour and a half in the hopes that we will be able to hear from all of our panelists and have time for a healthy discussion. So I will move on to address, or rather to introduce our panelists and then touch on the agenda quickly before turning it over to my colleague, Kathy. We have gathered folks today with different perspectives, viewpoints, and experiences with the hospice benefit. But this is an outstanding panel. I am going to make short shrift, take shortcuts, and make omissions when briefly providing their bios, all of which are available on their respective websites. Starting with my colleagues here at the Center for Medicare Advocacy, Kathy Holt, an associate director, joined the center in 2014. After earning her MBA, she worked as a hospital administrator. After earning her law degree, she became a special assistant U.S. attorney for the Department of Health and Human Services. She also, before joining us here at the center, founded a law practice to advocate for the needs of older and disabled individuals. Wei Wei Kwok is a senior attorney here at the center. Before joining us in 2002, she worked for AARP's Foundation's National Training Project. She worked as an attorney with the Legal Aid Society of Hawaii. And both Kathy and Wei serve on different boards. Katie Weary is the Director of Home Care and Hospice Regulatory Affairs at the National Association of Home Care and Hospice, otherwise known as NAC. Katie has over 30 years of experience in hospice and home health, including several executive level positions. She has extensive and direct knowledge of industry operations, regulations, and other relevant areas. In her current position, she communicates with regulators on hospice and home health issues and policies. Brian Lindberg, a longtime friend of the center, is Vice President of Health and Aging Policy at Healthsperian. He is a Washington, D.C. based advocate, policy educator, and lobbyist. He is the Executive Director of the Consumer Coalition for Quality Healthcare, which he helped create in 1993. He spent a number of years on Capitol Hill, including with the Senate Aging Committee, House Select Committee on Aging, and on the Subcommittee of Housing and Consumer Interests. He has worked on several different White House conferences on aging, worked with different agencies, and is on several boards. Ethan McChesney is the Policy Director for the National Partnership for Healthcare and Hospice Innovation. He's responsible for leading a wide range of initiatives, including but not limiting to monitoring policy and regulatory developments, interfacing with industry and government officials, and a number of other roles. Prior to joining the National Partnership for Healthcare and Hospice Innovation and Healthsperian, Ethan held multiple public policy focused roles, including with the National Coalition on Healthcare, and also spent time on Capitol Hill. So after I conclude these opening remarks in just a moment. We are going to move on to an overview of the hospice benefit provided by my colleague, Kathy. We'll then move on to beneficiary challenges that we have seen at the Center for Medicare Advocacy as presented by Weiwei. Then Katie from NAC will discuss, among other things, a consumer guide that we at the Center for Medicare Advocacy and folks at National Association for Home Care and Hospice jointly drafted and issued with respect to choosing a hospice. Then Brian will walk us through a discussion of a policy overview and hospice care principles. And then Ethan will close us out discussing program integrity and modernizing the hospice benefit. We will then, time permitting, have a discussion among the panelists where hopefully folks can react to things that other folks have said. And then, time permitting, an attendee Q&A. And as Matt mentioned, we will try to summarize some of the feedback that you gave us when we solicited whether or not folks have had a positive or negative hospice experience. So with that, I will turn the proverbial reins over to my colleague, Kathy Holt. Kathy.
Thank you, David, and thank you all for joining us today. As David mentioned, I'll be providing an overview of Medicare hospice coverage with a focus to help Medicare beneficiaries, advocates, and families participate in the hospice process to receive the best possible experience with hospice and their chosen hospice providers. The next slide reminds us that hospice matters. Sorry, I thought there was another slide in there. Ah, there we go. Okay. The end of life deserves as much beauty, care, and respect as the beginning. It deeply matters. And when the experience is done well, we know it is beautiful, care-filled, and respectful. The next slide is an overview of Medicare hospice coverage. Medicare covers hospice as a comprehensive program of care services and supports for terminally ill patients and their families. We'll look at those definitions in just a minute. Hospice changes the healthcare focus away from curing the condition to providing comfort or palliative care for pain relief and symptom management. On the next slide, we'll see how Medicare certifies or confirms hospice coverage. Attending physicians or a hospice physician certifies the patient as terminally ill, defined as medical prognosis of 6 months or less to live if the illness runs its normal course. The patient signs an election statement to elect the hospice benefit and to waive all rights to Medicare payments for the treatment of terminal illness and related conditions that are outside the payment to the hospice. And care must be received from a Medicare certified hospice. So on the next slide, we're going to describe hospice election periods. The patient may elect hospice coverage for 2 90-day periods, followed by an unlimited number of subsequent 60-day periods. And after the second 90-day period, so after the first 6 months, recertification associated with the third benefit period and every benefit period thereafter has to include documentation that a hospice physician or a hospice nurse practitioner had a face-to-face encounter with the patient. And that face-to-face encounter must document clinical findings supporting 6 months or less life expectancy, again, if the illness runs its normal course. The next slide discusses the hospice plan of care, or a roadmap to services. All hospice care and services that are offered to patients and their families must follow an individualized written plan of care that meets the beneficiary's needs. And the hospice interdisciplinary group establishes the plan of care together with the attending physician, if there is one, the patient or the representative, and the primary caregiver. The plan of care, as I mentioned, is the roadmap. It's very important for patients and their caregivers and friends and family to be very thoughtful about what the individual needs and what the priorities are for that individual, both from a comfort standpoint, but also from knowing how they want their remaining days to go and whether or not they're going to have that beautiful, care-filled, and respectful experience with hospice. So the plan of care is something to put a lot of thought into. And the next slide provides an overview of covered services and items that you might consider for inclusion in the plan of care. As a reminder, the purpose of hospice is to reduce pain or disease severity and manage the terminal illness and related conditions. So hospice services may be provided and covered by Medicare for these individuals that you see listed here. There are 10 listed individuals, each with their own unique, special process and expertise. And so again, as you're planning your plan of care, you're thinking about which of these individuals you will need in order to be included in that hospice plan of care. The next slide reviews some more of the services and items that are covered, including medical equipment, supplies, drugs to manage the pain and symptoms, individual and family or just family grief and loss counseling before and after the patient's death, short-term inpatient pain control and symptom management and respite care, and other reasonable and necessary hospice services in the patient's plan of care that are offered and arranged by and through the hospice. Again, that plan of care, very critical. The next slide provides links to model examples of an election statement and an addendum to confirm which items are not covered by Medicare. So now that a person has elected hospice, the next slide introduces levels of care and Medicare payments. Generally, Medicare pays hospice agencies a daily rate for each day a patient is enrolled in the hospice benefit. And Medicare will make that daily payment regardless of the number of services that are provided in a day, and also including days when the hospice provides no services. The daily payment rate covers the hospice's costs for providing services that are included in that important patient plan of care. Medicare makes daily payments based on one of 4 levels of care, and the next slide describes the first level of care. That first level of care is known as routine home care, and this is a day in which the patient elects to get hospice care at home and isn't getting what will be the next level of care we'll discuss, or continuous home care. But routine home care includes a patient in their home that might be a skilled nursing facility or an assisted living facility, or their home, an apartment. Routine home care is the level of care that typically is in existence when a patient isn't in crisis. And for that daily level of care, Medicare pays approximately $218 for the first 60 days, and then approximately $172 for day 61 and later. The next slide defines the second level of care. This is, as I mentioned, continuous home care. This is a day when both of these criteria will apply. The patient gets hospice care in a home setting that isn't an inpatient, and the care consists mainly of nursing on a continuous basis at home, with a minimum of 8 hours, but up to 24 hours in that time. Also, aid and/or homemaker services are available on a continuous basis during that continuous home care day. During brief periods of crisis, the continuous home care level will apply, but only as needed in order to stay at home. For that day, Medicare will pay up to approximately $1,565 or $65 an hour. The next slide describes the third level of care. This is known as inpatient respite care. This is a day that the patient elects to get hospice care in an approved inpatient facility, and we'll look at that on the next slide. And this is for up to 5 days in order to give the caregiver a rest. And in 2024, Medicare pays approximately $508 a day. The next slide defines the fourth and final level of care. This is known as general inpatient care. This is for each day the patient elects to get hospice care in an inpatient facility which is defined as an inpatient hospice facility, a hospital, or a skilled nursing facility. And this is for pain control or acute or chronic symptom management. And you see this in bold, which can't be managed in another setting. This is also sometimes known as the uncontrolled pain and symptom rule. If the pain can't be managed in a home setting, they have to be managed as an inpatient, then Medicare will pay. The length of stay and the length of covered stay depends on the acuity of a patient's symptoms. So in other words, it depends. And for this particular type of day, Medicare pays approximately $1,145 for that day. Now that we've defined the 4 levels of hospice care, the next slide looks at patient costs. Patient coinsurance applies to drugs and biological prescriptions. And so for each hospice-related palliative drug or biological prescription, the patient owes a coinsurance payment when they get it during the first 2 levels of care. So the routine home care or the continuous home care. And the coinsurance is 5% of the cost of the drug or biological to the hospice. The coinsurance for each prescription may not be more than $5. And as you could see from when I said the first 2 levels of care, there's no patient coinsurance when the individual is receiving general inpatient care or respite care on those days. And then there is a respite care coinsurance, which is 5% of the Medicare payment for a respite care day. However, that coinsurance amount may not be more than the inpatient hospital deductible, and it does include room and board in the respite care. The next slide provides a reminder of services Medicare typically won't cover. So this again is a reminder that treatment intended to cure a terminal illness or related condition is not covered by Medicare once you have elected hospice. But remember that the patient always has the right to stop hospice care at any time. Prescription drugs to cure an illness instead of for symptom control or pain relief. Care from any hospice provider that wasn't set up by the chosen hospice medical team. Room and board, not for services at home, in a nursing home, or in a hospice inpatient facility. But remember, yes, for short-term inpatient, those who need to have that uncontrolled and symptom management provided, uncontrolled pain and symptom management provided, or for respite care that the hospice arranges. And also not covered are care as a hospital inpatient, outpatient, or ambulance transport, unless it is arranged through the hospice team and for care that's unrelated to the terminal illness and the related conditions. Those are related to the terminal illness. The next slide addresses issues of hospice coverage when someone has traditional Medicare or Medicare Advantage. Until 2021, all Medicare beneficiaries elected hospice coverage through traditional Medicare, even if you were a Medicare Advantage enrollee. Beginning in 2021, CMS started testing inclusion of the Part A Medicare hospice benefit within the Medicare Advantage benefit package through something called the Value-Based Insurance Design Model, or VBID. The VBID model makes participating Medicare Advantage plans responsible for all Parts A and B benefits. So as of last year, the VBID model had 69 Medicare Advantage organizations providing care to approximately 9 million Medicare patients. So about 1/4 of the Medicare Advantage enrollees. And patients who are a Medicare Advantage enrollee should check with their Medicare Advantage plans to determine if they are participating in the VBID model. And we'll continue this information on the next slide. Hospice providers are not required to contract with Medicare Advantage plans, and if a provider chooses not to contract, the VBID model participating Medicare Advantage plan must continue to pay at least the equivalent to traditional Medicare rates for hospice care. Because the VBID model does not permit prior authorization requirements for hospice elections or transitions between different levels of hospice care. In other words, if you're in a Medicare Advantage plan, you can choose to go to whichever hospice, Medicare certified hospice meets your needs. And I know Katie's going to talk specifically about how different Medicare Advantage plans and how different hospices are from one another, and how it's so important to find the one that's the best fit for your needs. Finally, before I pass the program to Weiwei, the next slide provides citation to law, regulations, and policy for more in-depth resources. And now on to Weiwei. Mike, oh boy, sorry.
There you go.
Hi, sorry about that delay, folks. Okay, well, the hospice issues that people contact the Center for Medicare Advocacy about, oh, you could go back, sorry, generally fall into 5 categories that I will be discussing. And you may notice that some of these issues raise broader questions around how the hospice benefit is structured, how providers are reimbursed and regulated, the incentives that creates, and how it affects patient care. I'm very eager to hear my co-presenters address those important policy questions during this program. Thank you. Next slide, please. So one issue we hear about is when a hospice agency won't agree to furnish a particular item or service requested by the hospice patient or their family. And I've seen this come up where the patient has wanted a certain medication, or the family felt the patient could benefit from therapy like PT, OT, or speech therapy, or they felt that their loved one was dehydrated and should be given intravenous fluids. So an agency can deny a requested item or service that it deems to be curative because the hospice benefit only covers palliative treatment. But sometimes the line between curative and palliative isn't always a clear one. Some treatments slow the progression of an incurable disease, and some work prophylactically to prevent painful and distressing complications. So reasonable minds might disagree about whether such treatments are really curative or are actually needed to improve a patient's quality of life near the end of life. Agencies may also refuse items and services that they don't think will serve the purpose of palliating or managing the person's symptoms. So for example, an agency may feel that intravenous fluids will cause a patient more discomfort as their body is shutting down or increase the risk of certain complications. Another common situation is when a hospice determines that an item or service is not reasonable and necessary. Katie gave me some good examples here, such as where a patient has been taking a supplement like elderberry or turmeric, and Medicare generally won't cover supplements. Another example is where the caregiver is requesting a quantity of an item or service in excess of what the agency considers reasonable and necessary. So this sometimes comes up with incontinence supplies, or when the patient requests more radiation therapy sessions than is customarily provided in a palliative course of treatment. Along the same lines, the agency may find that the requested amount of services is not provided at the current level of hospice care. So, we hear from caregivers who have to work full time and are under the impression that under Medicare, a hospice nurse or aide can come out to stay with the patient 8 or more hours each day while they are at work. And we try to help these individuals understand that that amount of service is not available for patients who are properly getting the routine level 1 home care, level of hospice that Kathy mentioned. In these cases, we suggest that they explore whether Medicaid is an option to obtaining in-home support services or care in a nursing facility. An agency can also decline to furnish a drug that the patient wants that is not on its formulary. So if the drugs on its formulary are not providing the relief a patient needs, then the hospice must provide an alternative in order to relieve pain and symptoms. Note, though, that the hospice does not have to provide the specific drug that the patient requests if the hospice determines that a drug on its formulary or an alternative medication would work just as well. Next slide, please. Hospice agencies also won't cover drugs, items, and services that are unrelated to the patient's terminal illness and related conditions. Remember that someone who has elected hospice does not waive Medicare coverage for medical care, though, that is unrelated to their terminal illness. So as Kathy mentioned, people have the right to request and timely receive a written addendum listing the conditions, items, services, and drugs the hospice will not cover because it has determined them to be unrelated to the terminal illness. And providers and suppliers can request this addendum too, so that they have some assurance before providing and billing Medicare for services and items to somebody who's on hospice. Now, this addendum has to explain why the identified conditions and treatments are considered unrelated to the terminal illness, and also provide references to relevant clinical practice, policy, or coverage guidelines. And it must inform them that if they disagree with the hospice's determination, that immediate advocacy is available to them through the Beneficiary and Family-Centered Care Quality Improvement Organization, which I'm just going to refer to as the QIO. Next slide, please. So what options are available for hospice patients who feel they aren't getting the care they need? Well, a beneficiary or their representative always has the option to revoke their hospice election, and with the peace of mind that they can re-elect hospice at any time if they meet the eligibility criteria. An individual can also change hospice providers without revoking their election, and you're allowed to switch providers one time during any election period, each election period. So we always encourage people to go to Medicare's Hospice Compare website, and this is where they can compare among a list of Medicare participating hospice providers that service their zip code. This site gives information on how long an agency has been certified by Medicare, the average number of patients they care for each day. It also shows the percentage of patients that the hospice has treated based on type of terminal illness, such as cancer, dementia, stroke, heart disease, and respiratory disease. It also posts the ratings that hospices received from the Family Caregiver Survey. This is a questionnaire that is sent to a patient's family members and friends, asking how well the agency performed on a set of measures and whether they would recommend that hospice. Just as an aside, I recently went to the website and learned that there are a staggering 175 hospice agencies that serve my zip code. Chew on that. So patients also have options if they want to file a complaint. And they can file a complaint directly with their hospice agency. And some people do have success in working through their a problem that way. But of course, there are situations where that's not going to work, especially where there are serious quality of care issues. Example I have is, I heard about an elderly man who was caring for his frail, bedridden wife. And after 3 months on hospice, the agency had only sent a nurse once a month just to change her catheter, but had provided no pain medications, supplies, or even a single aid visit. So the patient's pain was not managed. She was developing contractures and a bed sore because her husband couldn't safely move her. And the hospice's physician had not reassessed her. And no one from the agency was returning their phone calls. So I advise that they should definitely try to switch to a different hospice agency as soon as possible. And also that they should file a complaint with Medicare and their state survey organization. So as far as filing a complaint with the QIO, on this slide, there's a link to CMS's website where people can find out if their QIO is Kepro or Levanta and contact information for that. CMS also has a fairly straightforward, standardized quality of care complaint form that people can use, and that's linked to here as well. Now, Katie reminded me that if the hospice agency is accredited, a person can lodge a complaint against the agency with the accrediting organization. People can also report their complaint to the state survey agency, bearing in mind that these agencies are often understaffed and have other priorities. So they may or may not take up and investigate someone's complaint, in a timely manner. Next slide, please. Another challenge we hear about is patients who face discharge after they've been on hospice for around 18 to 24 months on the grounds that they are no longer terminally ill. Of course, some people on hospice do rally or overcome their illnesses, but in the cases we hear about, it seems like the only apparent reason the patient is being discharged is because they aren't declining fast enough and that they've been on hospice too long. In some cases, these discharges may be motivated by the hospice cap. Medicare imposes an aggregate cap limiting the overall payment per patient that a hospice can receive annually. And in 2024, that's $33,494 per patient. Now, that cap may not adversely impact an agency serving a mix of clients that are on hospice for varying lengths of time. But if an agency has a high percentage of long stay clients in a given year, they are at greater risk of having to refund overpayments. Providers may also be afraid that if they have a higher number of long stay clients, it will trigger an audit by Medicare to determine if they are committing fraud by accepting patients who are not terminally ill. And which could result in financial penalties as well. But regardless of why it happens, these live discharges can put medically fragile patients and their families in a terrible bind. And we hear about families who are worried about how to cope with suddenly losing all of the services and essential medications, supplies, and equipment that their loved one was receiving from hospice. And we know that hospice agencies do not always provide sufficient discharge planning to prepare the family and connect them to resources that could help address or alleviate their burdens. Nor do agencies always comply with proper discharge procedures, such as seeking the opinion of the patient's own physician about whether the patient is still terminally ill. Next slide, please. Before discharging someone, the hospice must issue a termination notice informing them of their right to an expedited appeal by calling the QIO before noon of the following day. They also have to issue an ABN, an advanced beneficiary notice of non-coverage, that lets them know that they can choose to accept liability for continued hospice care and demand that a bill be submitted to Medicare for an official and appealable decision as to whether they are terminally ill. If someone requests an expedited or standard appeal, we recommend that they obtain support in writing from their treating health providers and clinical documentation that validates a terminal life expectancy. They can also request and review the hospice medical records and the notes from the hospice team for supporting evidence. And additionally, or alternatively, they can try to find another hospice agency that is willing to serve them. Next slide, please. A different kind of situation we are hearing more about lately is where the patient's family disagrees with the hospice level of care. Typically, they oppose the hospice's decision to switch the patient from general inpatient level 4 to routine home care level 1. We see this happen where a patient had been getting hospice at home, but then their condition deteriorated dramatically necessitating a general inpatient stay, which is only short term. But the patient's condition may have become so fragile or tenuous that the family is now afraid that they can no longer adequately care for the patient at home. So, they want to appeal because they feel the patient needs to stay in the hospital or the nursing facility or the inpatient hospice facility with their care covered by Medicare. But in this situation, there is no right to an expedited review. And in most cases, the patient will be switched to routine home care. And it's important to understand that if the patient remains in the nursing facility or the hospice inpatient facility, the patient will likely be charged for daily room and board. A fourth type of call we get is from patients who are finding it difficult or impossible to access hospice services at all. And this is a problem for patients in rural areas where there may be few or no certified hospice agencies. And we've also gotten calls from patients who have been denied services from hospice agencies because they require specialized equipment like ventilators, gastrostomy tubes, or expensive palliative medications. Now, I could be wrong, but I suspect that agencies might view such patients as potentially high resource and therefore less profitable to serve. Next slide, please. So the last category of calls we get concern confusion about coverage after hospice has been elected or revoked. And I thought I could illustrate this better with a fact pattern. So in this fact pattern, a Medicare Advantage enrollee on hospice falls and breaks his arm in early February. At the hospital, he revokes his hospice election under the mistaken belief that he must do so in order to get covered treatment. So he spends 2 days in the hospital and then 10 days in a skilled nursing facility for rehab. And then later he gets a hefty bill from these providers. Now, his Medicare Advantage plan says it's not the plan's responsibility to pay for care in February. Now, had this person known and stayed on hospice, the care that he received in the hospital and SNF to treat his broken arm could have been covered by the Medicare Advantage plan as unrelated to his terminal illness. But when a Medicare Advantage enrollee revokes hospice, the rule is that eligible claims will be paid by traditional Medicare until the first day of the following month. Thus, the enrollee here was treated as a traditional Medicare beneficiary with no Medigap plan and applying a 3-day qualifying hospital stay criteria for skilled nursing facility care. And he did not spend 3 inpatient days in the hospital. So you can see the complications that arise here with having Medicare Advantage and when you elect and revoke. And so with that, I will turn things over to Katie now, who is a true expert on all things hospice and can provide more insight on some of these issues and on how beneficiaries can optimize their experience with hospice. So thanks, everyone.
Thanks, Wei Wei. I am Katie Weary, the Director of Home Health and Hospice Regulatory Affairs with the National Association for Home Care and Hospice, otherwise known as NAC. I know many of you may not be familiar with NAC, so I do want to share, before I get into some details on a consumer guide that we've put together to hopefully help with some of these hospice decisions, I want to share a little bit about our organization. The National Association for Home Care and Hospice has been in existence since 1982 and really came together to represent hospices as well as home health agencies and home care providers across the nation. So Our members include a wide array of provider types. We have not-for-profit and proprietary organizations, urban and rural, public and private, as well as government-run agencies. And today, what I'm going to talk to you about is a consumer guide that NAC and the Center for Medicare Advocacy jointly developed. You can see on the next slide here that it is titled Questions to Ask When Choosing a Hospice. And the reason that we put this guide together is because there is a lot of confusion and there are issues that come up when somebody is receiving hospice care. And we wanted to develop some bullet points and some questions for folks to be able to ask of hospice providers that they are interviewing or determining whether or not they want to enroll with that particular hospice provider, as well as questions to ask after you have begun receiving hospice services. It's really important to know, as both Kathy and Weiwei have said, that each hospice has to abide by the same set of what we call conditions of participation in order to be certified as a Medicare hospice provider. However, not all hospices deliver those services in exactly the same way. So we wanted to be able to present these questions in a way that would start a dialogue with the hospices so that you can determine which hospice is right for your situation. And on the next slide, you can see two resources that are available additionally to the questions to ask when choosing a hospice provider document that we developed. These two resources on this slide are actually available from CMS. And the first one is the Medicare Hospice Benefits booklet, and the other is something called Care Compare. Now, Care Compare is a site that you can go to. I know Weiwei mentioned that she had gone there earlier to see how many hospices are available in her area to serve her or her family members. She can also see quality information about the hospice on Care Compare. And it provides information also about how long the hospice has been in business and the types of patients that they serve. The booklet that's pictured on the left-hand side is the Medicare Hospice Benefits booklet that CMS has put together for beneficiaries to learn a little bit more about hospice. However, the information in the booklet is very limited. It is limited to really a listing of what the Medicare hospice benefit is about. It does not address common questions or put the benefit in terms of what folks experience on a daily basis, how this Medicare hospice benefit is actually implemented and administered by the hospices and the differences that you might see in hospices. So that's why we took those everyday situations that we were hearing about and put them into the questions to ask when choosing a hospice document. We hope that this more comprehensive booklet that we put together is something that CMS will at some point in the future adopt so that beneficiaries can have a better understanding of the types of situations that they might encounter and the types of questions that they should ask so that they can learn about the hospice and what they might provide. So on the next slide, we are going to get into some details on the questions that are contained in the questions to ask when choosing a hospice provider document. As one goes through the process of becoming eligible for hospice or having a family member who is terminally ill and eligible for hospice care, there's two key time points in which they need to ask questions about hospice. And the first is when they're just going through what we call the screening process. If there's one takeaway from today that you should have, it's that hospices are not the same. We've said it several different times. We really want to drive that point home and make sure that everybody considers talking to more than one hospice when you're looking at those services, and using what we call these screening questions to help you decide, is this the hospice that's going to be best for my situation? Do they have the services, the breadth and depth of services that are necessary in my situation and what you're looking for? The next time point is after enrollment in hospice. Some care delivery questions should be asked, but the hospice may not be able to answer these types of questions during that initial discussion phase. And that's because they have not completed what we call a comprehensive assessment to determine exactly what each individual's needs are and how they can best meet those needs. So it's after that assessment has occurred and the hospice learns a little bit more about the clinical and medical condition of the patient, as well as information about their caregiver, if they have a caregiver, where they will be receiving services. And on the next slide, I took the liberty of pulling together a couple of screening questions from our questions to ask when choosing a hospice provider document that I think are the most important ones to ask for the questions that we received from all of you prior to today's webinar. You had an opportunity to put questions into your registration, and we looked at all of those questions and we looked at the themes of those questions. And based on that, I believe that these screening questions would be the most suitable to getting the answers to what you submitted, as well as helping to start that dialogue with the hospice so that you can have a better understanding of what hospice can provide, and they can have a better understanding of what you need, so that we can avoid some of those issues that Wei Wei talked about. So the first question is the hospice able to provide all the services listed above? And when you go into the booklet, you will see that we list all of the services that a Medicare certified hospice is required to provide. And we also provide a little bit of explanation about that, so that you will be able to ask, if you need aid services, okay, exactly what are the services that the aid will be providing? How often will they come to my home? Or if I'm not in a home and I'm in a nursing facility, how often will they come? How will they coordinate with the nursing facility? Will you be able to provide physical therapy? How much physical therapy? Those types of questions. The second question is, can I continue to see my physician and other healthcare providers after electing hospice care? So during the explanation of the Medicare hospice benefit that Kathy gave, she said that there's a waiver that Medicare hospice patients make when they elect the hospice benefit. And that is waiving their right to any treatment that is for the cure of the terminal illness for which they are in hospice, or for any conditions related to that terminal illness. Doesn't mean that they can't seek services from physicians and other healthcare providers, but once electing the hospice benefit, the hospice becomes, for lack of a better term, like a case manager. And that case manager either has to provide directly the services that the patient needs or arrange for them. Those are the only services that Medicare is going to cover under the Medicare hospice benefit. So by asking the question, can I continue to see my physician and other healthcare providers after electing hospice, you will get a better understanding, and the hospice will get a better understanding of the types of physicians or other providers that you might need to see, why you need to see them, and if the treatment or the reason that you are seeing them is going to be covered or not covered under the hospice benefit. And then the third one goes back to the visits that are to be made by the hospice team, because there's a full complement of team members, from physicians, nurses, and aides that we think of most often, to also social workers and chaplains and therapists, as well as possibly even volunteers. who's going to visit? How often are they going to visit? How long might the visit last? Those are the types of questions that you need to know. And also, if you are needing to go to a hospital or the emergency room, what does that look like? What contracts or what hospitals does the hospice contract with? If you go to an emergency room for a reason related to hospice care, how is the hospice going to cover that? It's extremely important that communication occur with the hospice before going to the emergency room or seeing somebody else, because again, the hospice may be able to provide a service or an intervention that can eliminate or alleviate the need for that visit, or they may have contracted with hospitals or specialists so that those services can be provided to you. On the next slide, we'll go through the questions that should be asked after the hospice has had a chance to do an assessment and they've had an opportunity to really look at your medical condition and what services are going to be required. So you're going to be looking at asking, are there any services, any medications, other treatment or equipment that you might need that the hospice is not going to provide or pay for because they consider it palliative. As Weiwei said, this is a decision that the hospice medical director, along with the patient's attending physician, if the patient has chosen an attending physician, because they don't have to, but it's the hospice medical director and that patient's attending physician, along with the hospice team, that will be determining what services, medications, and treatment would be considered reasonable and necessary, and palliative. Some of the other issues that Weiwei brought up could be alleviated by asking about the various levels of care, especially that general inpatient level of care, asking, for my condition, what type of situation might require me to have that general inpatient level of care, and how long can I have that care? A lot of problems come up in that general inpatient level of care because the hospice has to meet Medicare requirements in order to provide and bill for that level of care. And some of that criteria that's inherent in that particular level of care makes it really difficult when a patient is going to then be coming off of that level of care and going into or back down to that routine home care level of care. And a lot of those issues arise from caregiving situations that are inadequate and where a patient really needs to be in a facility. But the general inpatient level of care is not based on facility, it's based on the acuity of the patient. So it's not the location that dictates that level of care. And that's very confusing and very difficult to deal with for both the hospice and the patient at times. The other theme that came up in a lot of the questions that were submitted before this webinar are related to aid visits and how often there is an aid or a homemaker and what type of services those individuals would be providing, and how long does a typical visit last. Now, let me back up for a second about those aid visits and the average number of visits. So typically it's going to be 2 visits a week, but that should not be the limit if the patient's condition requires more than that. For instance, if a patient is incontinent and needs to be cleaned daily, then there should be daily aid visits unless there is a caregiver in the home that will be performing those visits, or sometimes the patient is able to clean themselves or their caregiver can clean them. So that's something to discuss with the hospice, and especially as the caregiving situation may be changing for the patient. So overall, I'm looking just here now at my list to make sure that I hit a lot of those questions and the main themes that came up in what was submitted with the registration questions. And the one area that we have not addressed yet, Wei did reference it in the common issues, also is difficulty getting on to hospice care. And that's one that is a real concern for us. There's two sides to this getting onto hospice care coin. The first is that a certification is required, as Kathy explained. The hospice medical director and the patient's attending physician, if there is one, do have to certify that an individual is terminally ill before they can go on to the Medicare hospice benefit. And there's certain criteria that needs to be met for that. And sometimes getting information about whether or not an individual meets that criteria takes a little bit of time. And it may take a little bit of time to also have that conversation with a patient's primary care physician or their attending physician about coming on to hospice. Sometimes physicians aren't comfortable saying to the patient, you know, there's really nothing from a curative standpoint that can be done. So we're going to admit or suggest an enrollment in hospice care. That's a discussion that is not an easy one and not one that's very comfortable for some healthcare providers to make. Sometimes patients are requesting hospice care and they're told, no, it's not time yet. There could be some different reasons for that. It may be that the patient's clinical condition doesn't meet the criteria. It could be that the hospice is concerned that the patient's on the borderline and they may not get paid by Medicare if they accept that patient. These are real issues that hospices are facing, and right now there's a lot of auditing going on in hospice care. And I've heard of situations where patients who have those diagnoses where it's not very clear if they're in those final stages of the terminal illness. It's really difficult to determine that, where Medicare is really denying payment to the hospice, and therefore the patient is not admitted to the hospice program until it's almost too late. And they may only stay on for a very short period of time, and staying on for a short period of time is not helpful because then the hospice is not able to really address the pain and symptoms that are occurring, and they're not able to prepare the patient and the family for the transition during that final stage. So a lot to be considered in coming on to hospice care. And if you feel that you want hospice care and you are not able to receive that, it is okay to reach out to a hospice directly and ask for a consultation. And with that, I could speak for a very long time about the questions that we have in the document and all the various situations that one might encounter, but I think we've covered the main ones here, and we'll have an opportunity at the end of the webinar to discuss some of the other issues that you may be thinking about or that may come up as we go throughout the rest of the webinar. For now, I'm going to turn it over to Brian.
Okay, well, thank you, Katie. I appreciate all that. That's great information. And thank you, David. And special thanks to you for organizing us and producing this event. Next, let me say what really it's an honor and a pleasure to be joining the Center for Medicare Advocacy's team today. You can tell the great information you're putting out there, but I have a history with the organization. Judy Stein and our wonderful Al Chiplin, who we miss so much, and many of the center's staff have been friends and colleagues for decades, so it's great to be here. And another pleasure of mine today is to bring to the center's audience one of the best and brightest in the hospice space, and also an office mate of mine, Ethan McChesney, who will follow my presentation today. So let's go to the next slide, please. This is just to give you a little bit of a flavor about CTAC. We've been looking forward to this kind of an opportunity to collaborate more with the center for a long time. As you can see here, CTAC is a coalition of more than 200 organizations that share our vision of person-centered care that meets patients' goals and honors their dignity. We strive to represent the voice of the patient and the family and their interests when we advocate with legislators and work with policymakers, decision makers, and advocates to craft policies to best serve them. So on my next slide, on these next couple slides, I'm just gonna briefly tell you the other areas we're working in. It's not just hospice. We work to improve access to advanced care planning, community services and supports that individuals with serious illness need. We've been working for many years on payment models to better pay for this kind of care. We work with caregivers to try to increase their support, and telehealth. And at the core of all of that is trying to advance equity and dismantling systematic barriers to high quality serious illness care for traditionally underserved communities. We can't forget that some of the very best care that we may be hearing about today isn't getting to some of those communities. On the next slide, I just mention here that we're quite active in the regulatory advocacy space as well through our esteemed colleague, Marion Grant. You can see here a bit of what we're working on regularly: ongoing dialogue with the administration, the executive branch work that's needed to be done here in DC, comments on proposed regulations, and fortunately, we're pretty pleased with the administration's willingness to pay attention to what we recommend. So my next slide, finally, the topic of the day. One could imagine with serious illness and advanced illnesses driving our agenda, hospice has been a key part of the work of CTAC for more than 10 years. And you can see on the next slide here that I'm starting my comments with hospice oversight and integrity issues, but I'm dividing my thoughts here into hospice, quality, integrity, and then secondarily hospice modernization. So let me just start with what you see here. We have been very pleased to be at the table discussing hospice, which is really, we have to remember, one of the most well-designed and positive programs serving Medicare beneficiaries. But we've been up on the Hill discussing hospice for the last couple years, in particular with Representative Blumenauer and Senator Warner. They have been looking at both aspects of the program, as I mentioned. We're particularly concerned that all individuals with serious illness and their caregivers, especially those who are underserved or under-resourced, have quality of life on their own terms near the end of life. And issues of hospice program integrity and quality are obviously critical to reaching that goal. And concerns about the actual fraud and deception of those nearing the end of life, these can lead to be extremely difficult situations, and in fact catastrophic to the individual or their family who's in hospice. The hospice provider community has risen, I believe, to the occasion and worked well with CMS to address many of the concerns that you may have read about, including in the article that David mentioned earlier. CTAC believes that these efforts will be and have been helpful, but we've focused our attention on what this means for the needs of the individual with a serious illness and their family caregivers. So we have included in our work a call for important consumer protections, including information, quality assurance, and consumer rights. So over the next months, we'll be developing a set of consumer protections, which may or may not end up in legislative language, but we'll be working on those, and we plan to collaborate closely with the center. So on the next slide, you can see the second set of issues that we have been very focused on. The fact that there are quality and integrity issues being discussed on the Hill may actually lead to opportunities for what I call hospice modernization. And in fact, if we can prove that the program is improving, fraud is reduced, we may actually have resources to dedicate toward that set of modernizations. Ethan will say much more about the notion of modernizing the hospice benefit program under Medicare, because his organization is leading the way in that. But let me give you my organization's viewpoint on this. We strongly support modernization of the benefit, that would address in particular the limitations of the 6-month prognosis rule. We also believe that we need to allow concurrent care coverage, and we believe that we could, if we do this right, come up with modernization that could lead to upstream palliative care services and supports for those that may want hospice but don't need it yet, or they may be fearful of signing up for hospice because of the worry of losing certain benefits. One of the things that we believe is a key component of modernization is comprehensive assessments. We believe it's necessary to improve the quality of serious illness care upstream from hospice, and that should include the patient and the family caregivers being assessed appropriately. The comprehensive assessment should include the person's physical, social, psychological, and spiritual needs and the needs of their caregiver on an ongoing and standardized basis. While already true for hospice, this would also apply to anyone living with a serious illness and help identify appropriate services when needed, particularly palliative care. We think this assessment and subsequent care coordination is essential to ensuring the necessary resources are made available to the individual based on their care preferences, and that the most efficient and often also most cost-effective service delivery is used. This is important regardless of how much the palliative care services and community-based supports and services are covered in a modified Medicaid benefit. We believe that the Aging Network, for example, the area agencies on aging that many people know of, and community-based faith organizations are in a good position to help improve the assessment and coverage in this area. Some already are doing it. Hospice holistic approach to care, its patient and family satisfaction, puts it in a strong position to work with others to make key elements of the program more widely available to those with serious illness who are not eligible for the benefit yet. Further, we think upstream success with those serious illnesses will likely lead to more acceptance of the hospice program and earlier utilization of the benefit. Let's move to the next slide here. I'm not going to go through all of these principles today in detail, but we'll make them available to in the slides, of course, and then on our website. These principles were originally designed to help develop and evaluate care and payment models for serious illness. We've modified them to help guide the evaluation of revisions to the Medicare hospice benefit and to support providing care earlier in the course of a serious illness. Core principles like this provide guideposts that can be used to evaluate hospice care and any modernization proposals that come forward. Hospice is a holistic approach to care, and any changes to the Medicare hospice benefit should continue to ensure that all individuals living with serious illness have access to equitable care reflecting our core principles, regardless of who pays for that care. Overall, you can see care should be person-centered and family-centered. The care should be inclusive, including reducing inequities and disparities and removing barriers to access to care. It needs to be comprehensive in approach, and any program should assess each person's physical, social, psychological, and spiritual needs. On the next slide, I continue with our care planning. A care plan is developed using shared decision-making based on those needs and persons' individual goals and preferences, and we believe this is critical. Most of you know that hospice includes an interdisciplinary team. That should be the kind of team that works its way upstream as well, so that if you have a serious illness and you're receiving palliative care, you have a full range of healthcare professionals and supportive service providers to help make sure that, first of all, your care is treated properly, but then you're not also going in and out of hospitals, ERs, et cetera. And of course, care should be accessible 24/7, and it must be coordinated, comprehensive, and with seamless transition between various sites of care. And the last slide on the principles includes some of what we believe are important for payment requirements, and the consumer protections I mentioned before. We really believe that we've got to assess the program, make sure that there's access to understandable, unbiased, accurate information, that there should be quality assurance systems should be in place to monitor and improve the quality of services, and that consumers have the rights. They have clear, explicit rights, appeals regarding benefit services. Quality should be addressed quickly and fairly, particularly for this population. So let's see, my next slide is a thank you, and looking forward to any questions, comments you have. And now I will turn it over to Ethan with NPHI.
Thank you, Brian. Good afternoon, everyone. Great to be here. What wonderful information we've heard thus far today. I'm joining you from Washington, D.C., serving as the policy director with the National Partnership for Healthcare and Hospice Innovation. Today, I'm going to be talking about a couple current ongoing trends, as you've heard from other speakers today, are revolving around program integrity and the audit burden in hospice. And then, as Brian just alluded to, hospice benefit reform possibilities moving forward. Before I jump in, just a little bit about NPHI. We're a membership organization based in DC, but with members, 100 plus nonprofit, community-based hospice, palliative care, and advanced illness providers in 37 states in DC. Really, we exist to serve the unique needs and interests of the nonprofit segment of the hospice community. So with that, I'll jump in. And on the next slide, there's just a sampling of some of the recent media attention that hospice program integrity has received. As has been mentioned multiple times this afternoon, a ProPublica New Yorker expose that came out around Thanksgiving of 2022 really jump-started a conversation nationally and especially here in DC on fraud, waste, and abuse issues in hospice. Last year, NPHI, in conjunction with the other large national hospice organizations, including NOC, which Katie spoke from earlier, put forward consensus program integrity recommendations to address some of the really horrible instances of just outright fraud that we were seeing, especially concentrated in California, Arizona, Nevada, and Texas. Though, as you'll see, and as you heard throughout the afternoon, hospice growth has been occurring all over the country, and the vast majority of that growth has been in the for-profit segment of the industry. Not to say that there are this is not all about tax status by any means. There are good nonprofit or bad nonprofits, good for-profits. It's really about the provision of quality care. And that allowed our four organizations to come together to put forward consensus recommendations to address some of those issues. On the next slide, you can see how NPHI thinks about the regulatory space and how we've broken up these two issues. On the top, you have our work to modify survey and certification requirements, to tighten oversight of accreditors, to increase overall scrutiny on the hospice program, and especially new entrants into the space. So Last year, we worked, as Brian alluded to, with Congressman Blumenauer and many others on the House side in urging Congress to ask CMS essentially what more can be done to cut down on fraud, waste, and abuse in this space. CMS ultimately last summer took 17 of our recommendations and moved forward with them in some form or fashion, and we're very much still in ongoing dialogue with CMS. But as Brian and others have alluded to, we've been fortunate to have strong, proactive, productive, genuine working relationships with this administration, which really has attempted to address some of the outright instances of fraud that we've seen across the country, especially in the years since COVID, where we've seen just a tremendous influx of new providers. Similar or in parallel to that, there is a broad conversation ongoing in the hospice space around how audits are focused and targeted in hospice. It is the belief of many well-meaning providers, regardless of tax status, that audits are really inappropriately targeting certain providers based on the potential for recovery as opposed to where bad actors truly are. And so we're working very closely with the Center for Program Integrity within CMS and CMS writ large to attempt to refocus hospice audits where bad actors are and prioritize a list of or a series of patterns and practices that we feel are indicative of poor quality care. And so those two tracks of work continue to move forward up to today. On the next slide, you can see a little bit more detail about what we proposed and then what CMS did last year to address fraud. I think some of the big things I'll call out, we recommended that CMS revoke the certification of non-operational providers. CMS then did site visits to all Medicare certified hospices nationwide. That's over 7,000 hospices, and took administrative action against more than 400 of them. They also, in rulemaking last fall, instituted a prohibition on the transfer of Medicare billing privileges of a new hospice for 36 months after their certification, among many other steps that they've taken. Now, what more could CMS do? On the next slide, you can see two proposals that the community has put forward that haven't been taken up by CMS thus far. One is we've called for a targeted moratorium to limit the enrollment of new hospice providers in certain geographic areas where there's already a high risk of fraud. So those concentrated primarily in those 4 states, but you do see fraud, waste, and abuse activity not necessarily occurring just in those 4 areas. In addition, we've proposed that CMS adopt a sort of red flag criteria to require further scrutiny of certain providers based on a handful of metrics that we think are particularly indicative of fraudulent behavior. So we've worked with members of Congress to urge CMS to take those actions. On the next slide, you can see just a little bit a similar set of solutions related to what we've proposed to address the audit burden. I won't read through all of these by any means, but what I'll focus on is that we have called on CMS to refocus audits on questionable patterns and practices. I say questionable generously. A few of those, for instance, might be reducing the excessive auditing of the general inpatient level of care. As you've heard, most care in hospice is provided at the routine home care level. However, GIP care gets far more audit attention than you might expect. Additionally, we've called on CMS to focus audits on providers that have a high percentage of either long general inpatient or routine home care lengths of stay, high live discharge rates, et cetera. There's also a series of outliers that CMS already collects called the Pepper report that we've called on CMS to use to help target audits better. In the interest of time, I'm going to keep going here, and I do want to talk about modernizing the Medicare hospice benefit. This is, as Brian alluded to, really NPHI's core legislative priority over the coming years. The Medicare hospice benefit was established in the early 80s, has not been meaningfully modified really since then. And so there's tremendous opportunity to improve the benefit and really bring it up to speed with clinical and operational realities of providing hospice care in 2024. A few things I'll touch on here. On the eligibility side, we are really trying to move away from the 6-month prognosis and base eligibility on more objective measures of patient need. So for instance, acuity, frailty, functional need, and we're working on how we can capture and define those in an eligibility determination process. On the payment side, we would like to move hospice into the 21st century. It is the only benefit one of the only benefits without a quality tie-in. So the quality data that you can see on the Hospice Quality Reporting Program has no impact on hospice reimbursements. So we'd like to move in that direction with more of a payment structure that modifies reimbursement based on the level of care that a patient is receiving and the type of need they have. So that could look like a risk adjustment, case mix adjustment. Lots of work is ongoing in this space. On the next slide, you can see a little bit of background as to how NPHI has thought about this work, kind of where we stand and where we're going. We are working very closely with a high-profile actuarial firm to model out a lot of these different proposals, look at their cost-benefit analysis, look at whether they're budget neutral, as is needs to be the case for most legislation that moves nowadays. And we hope to have some real substantive benefit design alternatives to share with the hospice community later this year. So with that, and I know running out of time here, thank you all today, and happy to take any questions. If we've got some time, I'll hand it back to our moderators.
Thank you so much, Ethan. Thank you, Kathy, Weiwei, Katie, and Brian as well. We have covered a lot of ground, from the practical, from what is covered under the hospice benefit, to what do problems look like when they arise, to what to look for when choosing a hospice provider. We also touched on a lot of policy considerations, including consumer principles, program integrity and audits, and the future of the hospice benefit. If all the panelists could come back on camera, I know we have limited time left, even though we added an extra half an hour to this webinar. I first wanted to start by seeing if there were any things that you wanted to say that didn't get a chance to say, or comments in response to things that other folks have said, or questions you wanted to pose. We'll start with that.
So I'd like to ask a question, and I guess it would go to Katie, but anybody could answer it. If someone has a rapidly changing condition, what's a practical amount of time or way that someone could change their plan of care? How often can the plan of care be changed?
Daily, even multiple times a day. What should be happening is that anytime somebody is having rapid changes, the hospice team needs to be aware of that. Now, sometimes they're aware of that because they're there and they're making a visit, but changes can occur even when you're outside of that visit window. So it's really important that patients and families communicate with the hospice to let them know about a change, because if they don't know about it, they can't address it. But once they know about it, they should be addressing that, whether that's to immediately get some medication to the patient or some other interventions that need to take place. There should be constant communication in those types of situations where somebody's changing like that, and visits should be made and new orders for care.
Thanks.
Thank you, Kathy and Katie. One question now. We did get some questions before the webinar, and we did our best to incorporate answers to those questions in the various presentations. One question came up on something you touched on, Brian, was concurrent care. Can you talk a little bit about, or anybody talk a little bit about what concurrent care is? Is it currently available in Medicare or in the hospice benefit at all?
Mm-hmm. Well, I can start and let Ethan jump in there, but this is the data shows us that many individuals who end up on hospice with very few days, literally, of their lives left. And often it's because they may believe that they want to continue other care, that other treatments, curative cares, in quotes, curative cares, that are available to them until they sign up for hospice. And as I think I think a couple of the panelists mentioned, those curative cares are often palliative in nature as well. So even if you accept that you may not be going to be cured by the treatments, sometimes they have great benefit for the rest of your life. And so that's one of the reasons people don't jump onto hospice, because they don't want to give up those cares. Ethan, is there more we should be saying there?
I'm muted, of course. That was great, Brian. I think what I would add is just that this is a very active area. And I think one area of hospice policy where there's opportunity to make incremental improvements, and this doesn't have to be necessarily part of holistic benefit reform. There has been some Center for Medicare and Medicaid Innovation action looking at concurrent care through various previous demonstrations. Congressman Blumenauer has been very interested in concurrent care for the dialysis, ESRD population. So I would just add that very active, although not currently available under the benefit, definitely some an area that folks are interested in and are headed towards, I would say.
Great, thank you. And Matt, I'm going to put you on the spot for a second. I know, again, we tried to address many of the questions that we got ahead of time throughout the presentation. Matt, have you been able to identify any thread or key area of focus with respect to any questions that folks might have typed into the chat?
Oh, we don't have any questions, David. Just kidding.
Okay, great.
Yeah, actually, there were a couple themes that I saw here. Ownership, private versus nonprofit, and private equity firm ownership. People wonder, is there a difference in care quality? And Ethan touched on it very, very quickly in his presentation. And given that there is some evidence that private equity is just a bad idea for healthcare, should people be able to look into ownership of hospices? Oh, looks like you're muted, Ethan.
One day I'll stop doing that. Very fair question. I think I'll take the private equity piece. There is tremendous concern about private equity influence in hospice. I mean, the ability of private equity firms to enter this space is frankly relatively easy. There's little overhead with hospice compared to some other healthcare provider types. There's fairly stable Medicare reimbursement, et cetera. So if I'm a provider and I know I can come into this space and reap a 20+% profit margin, as MedPAC has shown, then frankly it's quite attractive. So and we do know that quality of care from PE-backed providers lags dramatically behind high quality for or nonprofit providers. So that's definitely an issue that is becoming more prevalent, and one that I think committees of jurisdiction on the Hill are also interested in, not just relative to hospice, but across the healthcare continuum.
Yeah, I would agree with that. I think there's some interesting reading out there for whomever asked that question. There's Larry Atkins did an interesting piece on private equity covering nursing home care as well. And in that space, I think there's some good evidence that there's differences in quality, as we've seen in the space for hospice as well. And also just there, you'll see more and more on this. This is a major issue that a number of members of Congress care greatly about and will have hearings about.
Right. So,
and if I could,
sorry,
Dave, just add one final comment here. I think, regardless of ownership type, I think folks really need to be looking at the quality of care of providers, because Ethan even said, regardless of tax status, we've got quality of care issues, especially in some areas of our country. So paying attention to care compare and asking those questions so you can really get at what is this provider going to deliver is important.
And to that point, on just the variance between the hospices and people's experience with hospice, just want to, out of respect for all of the panelists and out of respect for folks that are attending, close by thanking folks, not only for attending the webinar, but also for your feedback in the registration process, during which we asked if people had positive or negative experiences about hospice. And not surprisingly, it was decidedly mixed. A lot of people said that they had mixed experiences, even a good experience with one family member and a bad experience with another family member. I think a lot of the panelists touched on the individual problems that came up, but I think it's really indicative of the state of play. And the range of comments that we got ranged from overwhelmingly positive and people talking about how wonderful and compassionate and dedicated hospice workers are, and just poignant statements such as one person's praising the fact that the hospice workers sang with her mother, and at the same time they caught medication errors at the facility, and describe hospice workers as angels, as a godsend, and hospice saved our lives. But then on the negative side, there were plenty of people who had negative experiences, including many of the issues that we talked about today. Having access to certain care that they thought that they needed, starting on the hospice benefit, and one person, saying, my husband was sent to hospice, they took him off his pain meds to titrate his dose, and he died in extreme pain, which is obviously the exact opposite of what one would like to see for hospice. Again, would like to thank all the panelists, Kathy, Wei, Katie, Brian, Ethan, and all of you for your interest in this topic. The recording of this webinar should be available on our website soon. Apologies for errors and moving the slides. I'm going to blame that on the nationwide cellular outages, even though that makes no logical sense. But thank you again, everyone. And Matt, I don't know if you have any concluding remarks, but we appreciate your time.
Yep, just want to echo your thanks and mention that for anyone who's interested, we have another webinar coming up, still free for all, a discussion of Medicare and oral health on Wednesday, March 6th at 2 o'clock. You can register right now at medicareadvocacy.org/webinars. And with that plug, I will now end today's presentation. Thank you all.
Thank you.